So we move on to our next panel discussion that's on locoregionally advanced larynx carcinoma. The moderator for this session is Dr. Arvind Krishnamurthy, and he's a professor head and neck surgical oncology at Cancer Institute, Adyar, Chennai. The panelist for this session is Dr. Aditya Joshipura, currently working as consultant head and neck surgical oncologist at HCG Cancer Center, Ahmedabad. Dr. Asif Sheikh, consultant medical oncologist at Bharat Cancer Hospital, Surat. Dr. Jignesh Dubbal, consultant radiologist at HCG Cancer Center, Ahmedabad. Dr. Jyoti Dabholkar, senior consultant in the Department of ENT at HN Reliance Foundation Hospital and Research Center. Dr. Prapti Patel, consultant radiation oncologist at SIMS Hospital, Ahmedabad. Dr. Rajesh Kantaria, medical director and chief of head oncosurgery at Kailash Cancer Hospital and Research Center, Goraj. Dr. Samrendra Dash, consultant radiation oncologist at Apollo Cancer Center, Ahmedabad. And Dr. Tashneen Rahman, currently working as professor and head of department of head and neck oncology at Dr. B. Barua Cancer Institute, Guwahati.
Thank you, madam. I think good evening, everybody. Welcome to my panelists. I think they need some more chairs. No? It's a big panel. I think 4 surgeons we have, 2 medical oncologists, 2 radiation oncologists, and a radiologist as well. So I think it's a well-balanced panel. But before I start, I think I would like to sort of okay. Right. So before I start, I would like to sort of, thank the organizers, Dr. Kaustubh, Asta Associates, everybody. I think it's been a long association. I've been here many times, and it's always a pleasure to be here. It's a tough job to do this panel. I think Dr. De Cruz has already given all the philosophy about laryngeal cancers. And I think he introduced the term of intermediate laryngeal cancer. So what I understood was early and advanced. So I think cases, but I enjoyed your panel as always, sir. And I think, so what I thought is I had to sort of change a couple of slides. I thought instead of putting the philosophy, which sir has already elegantly taught us over the years, we'd possibly discuss some case scenarios in the time that is available. So just some background slides of larynx cancers, this one. And just to define the terminology, I think sir has said that, it's early laryngeal, intermediate, and locally advanced. So according to sir's book, if advanced is only T4 with laryngeal dysfunction and cartilage erosion, I think the panel is over because there's only surgery in the fit patient. But I thought that I would sort of, present some other cases as well. So I just wanted to understand from everybody, what is, maybe the surgeons, what proportion of their cases would be the advanced group, considering, Madam, Dr. Jyoti.
Yeah, so Arvind, we all know that our India, even though the presenting symptom is change of voice, and still we see very, very advanced laryngeal cancers. So, and till this era of discussion of the CTRT and everything happened, patient used to go for a laryngectomies. I'm talking of 20, 25 years back. So we
a ballpark figure or something like that? No, anybody, any thoughts? Are they seeing more advanced nowadays than earlier?
Probably
Aditya?
the age at which we are seeing the patients is moving towards the younger patients. Right. But probably otherwise I have no idea what.
Sure, okay. Any thoughts, Aditya? You just wanted to sort of.
If we just look at the incidence of laryngeal cancer, I'll be talking about my own institute.
Right.
So we have been seeing a definite increase in P4As and N positive laryngeal disease, especially in the post-COVID era.
Right,
so I just had a discussion with a statistician also. What we saw was that the incidence of locally advanced, as you would define it as say T4A or nodal positive diseases, has gone up to around 60 to 65% in the patients that we see.
Right. No, so that was also
it used to be around 50% for our department. And so personal experience, yes.
As Madam said, it was always high, but I think there was some publication in the Indian Journal, in the International Indian Journal of Head Neck Surgery, that possibly we are seeing much more after the COVID pandemic. In fact, that was also our observation, but we didn't really sort of look hard into the data. So my other thing is, of course, it's a panel, multidisciplinary panel. The other important aspect I just wanted to understand from each of the panelists, some of the endpoints of clinical trials, and this is relevant, I think, so also briefly discussed, was what do you feel is the important endpoints? Like, there have been many endpoints for, in general, I think this is not just for any cancer, these are certain endpoints, but for larynx, we do have some other softer endpoints that are actually been a part of the landmark trials as well, apart from, say, the overall survival or disease-free survival and quality of life. Of course, these are the standard, but then we have issues with voice outcomes, and there's some new outcome called as laryngo-esophageal dysfunction-free survival. So any thoughts on, should we go in for such softer outcomes, or do we actually rely on the hard outcomes of overall survival or disease-free survival? Rajesh, I think.
Overall and disease-free survival are, the standard outcomes which will matter. But a functional laryngeal preservation is something which, we would aim to,
Right. Any other thoughts from anybody?
Basically, the same thing. Basically, patient should be having a good quality of life. He should be speaking. So
Right.
provokes insertion,
Right.
whatever may be the cost, whatever may be the thing, but there are NGOs who are supporting, like Cancer Patient Aid Association. That should be our responsibility. So quality of life and a functioning larynx, basically.
Right. No, because if you take, say, overall survival, I think traditionally surgery, it's always given the best in terms of overall survival, but because we discuss about a lot of these softer outcomes, like, quality of life, voice outcomes, laryngo-pharyngeal dysphagia-free survival, I think that's where I think a lot of data. So Dr. Kostab, you wanted to sort of make a point on that.
So I was going to say the same, that, any disease in head and neck, when you have an excellent survival, you start talking about other things, the quality of life and things like that. The larynx has, over a period, is the same story, that we had quite a good survival rate, pure laryngeal cancers 20 years back, but then we were not preserving larynx. So then the quality of life came, and then all these trials started, and probably the world stretched it to another extent, and then probably the answer is in middle somewhere, that every modality has some place in that.
So I think we all understand, like, although overall survival, disease-free survival, they are all hard endpoints, are still relevant also, but in case of larynx, because of the issue of, perceived poorer quality of life, perceived, I'm telling, like, it may not actually be, because of, Madam said, like, a lot of the rehabilitation options that we do have. Abhishek, you wanted to make a point, because you elegantly sort of,
just to
came
add
up.
on.
Please, Doctor.
Sir, I mean, this is the exact sequence where you are moving from the 90s to the 2020s.
Right.
So initially, because the upfront treatment was laryngectomy, we didn't even consider about functional larynx.
Right.
At that time, at that period, we were thinking about preservation. So now you have moved from preservation to function.
Right.
So now is the era where you have to incorporate these endpoints. The last one, the laryngo-esophageal dysfunction-free survival, as you mentioned, right?
So I think the world is sort of moving that way. Abhishek, you had a point.
Yes, same point. In fact, the laryngo-esophageal dysfunction-free survival was coined by Professor Kian Ang and Lefebvre, I think, was it in 2010, and they've, kind of exhorted everyone to report their trials in this endpoint. So this is one endpoint which should be chased, at least in terms of trials which are reporting results.
Right. And the other thing is to be pragmatic. What happens is, when you want to do randomized control trials, or when you want to do trials, you have outcomes that you can sort of get more easily. I think although overall survival and disease-free survival are sort of gold standard endpoints in any trial, I think it takes a little longer time for it to come. Dr. De Cruz, you had a point, sir. You are sort of
very good workshop. It's on YouTube on endpoints in head and neck. I think everybody who does trials must read it.
Right.
And they accept now event-free survival in head and neck. It's a YouTube free link if someone can Google and see. It's about a 4-hour program, and they've discussed every endpoint, just for completion for the youngsters.
So your take, sir, do we sort of go in for this endpoint right now as is being said, like laryngo-esophageal dysfunction-free survival? Is it relevant, or is it something that if we were to do a trial today, if some of the youngsters wanted to, so what should this endpoint be chased?
I think again he is referred to that paper by Ang and all. They've told you what the endpoint should be. It should be a laryngectomy-free survival when you're looking at these organ preservation approaches.
Right.
But otherwise, it's more pure to have survival as an endpoint.
Right.
Any good study should have survival. And in head and neck, because we fail loco-regionally rather than distant, an event-free survival is considered as robust as an overall survival.
Right. Great, sir. Okay, I think we'll just move on to the case scenario. I think 55-year-old gentleman, performance status 1, smoker for 35 years, old tuberculosis, diabetic. Clinically, of course, there was a laryngeal expansion and bilateral neck nodes, I think, and this is the flexible endoscopy picture, I think, just to sort of see there's a predominant growth which is there on the left supraglottic area, kissing ulcer on the right side, actually fixing the left cord. And again in the imaging it was actually exolaryngeal spread, like, you know. So how do we sort of, you know, go about? And the other concerns, as I said, was that because obviously this patient had a little amount of breathing difficulty, but not a frank stridor. It comes to you. How comfortable are we possibly to evaluate these patients in the OPD, Dr. Tashni?
Yeah, if a patient comes like this, first I would like to go a Hopkins examination in my OPD. Yeah, then I would like to go for flexible laryngoscopy.
Right.
And
my issue predominantly was with the biopsy. For example, sometimes when we biopsy such lesions, you know, there is a tendency to aggravate these, right? Because these patients are already airway compromises there, though this gentleman is doesn't have a trach right now. So that's
then
with that
I would like to
perspective.
go for a functional test. I'd like to send to speech pathologist for
Right.
BFSS on FAS in my OPD.
Great.
And BFSS to see the penetration aspiration score.
Great. Okay,
Because this is
perfect, that will be
surely-
done.
yeah.
But the other thing, Rajesh, would we sort of, my simple question is, would we sort of, you know, be comfortable biopsying them? Or do you say that, no, I would actually achieve an airway by, say, doing a trach? No, because obviously the image just shows some exolaryngeal spread. So I just wanted your thoughts in real world. How do you sort of go
if
about
you
this?
see the left vocal cord and the lesion which is exophytic,
Right.
so biopsying that area, you know, which actually open up the airway.
Right,
You
right.
know, in that. So it will be, you know, and biopsy you will require
Right.
to plan your further treatment. So I would go and do a direct laryngoscopy and biopsy.
And
the lesion.
biopsy
Yeah.
these lesions.
Yeah.
So do you ever debulk some of these patients or something of that sort during the course of biopsy? That's what you're actually mentioning. And is that a
Not
practice
exactly
at all? Or?
debulking,
Right,
but
okay.
yes, it opens up the airway most of
Right,
the times, and
right.
you'll be able to assess also whether there is fixity because of the bulk of the tumor or the
Right,
cricoarytenoid joint. That also you'll be able to assess while.
Right. Yes, sir. Please, doctor. Come to the mic, Dr. Hari Bhakti, sir.
Look at this picture. This is, I mean, I would not do this. You know, it's a dangerous airway. You should only do all those things if you can get a tube in.
Right.
If you can't, and I think it's going to be difficult for any anesthesiologist to. You showed us the CT.
Right.
It's not an easy patient to intubate at all. So
Yep.
please let us hold our horses. We can't recommend all these things.
Right.
You'll send the patient into stridor.
Right.
You'll precipitate a major catastrophe.
Right.
So let's be.
Yeah, that's the point exactly. I wanted to sort of, you know, get it out. Like, no, that
Now
was
get
the,
it here. Now,
Right.
when I look at this picture,
Right.
I can tell you, it's a very, I mean, I think laterally, but if you want just a histologic proof
Right.
before putting onto some, you can even stick in a needle anteriorly. You'll
Right.
get tumor out there.
Absolutely,
It's
yeah,
not difficult. You don't have to subject a patient to the risk of GA without being intubated.
Right, absolutely. So, in fact, that was the point I was trying to make. Airway management and the role of a pre-evaluation tracheostomy. And that's what I had actually wanted the panelist. Yes, madam. Aditya, you had a point. Like,
If
please.
it was limited to that patient, I probably might be mistaken, but I could see a tracheostomy in situ.
Right.
So probably the patient had an airway compromise.
No, when he came, he did not. Then subsequently, we sort of, did it, and, because again, we wanted to be a little safe, the sense. So that's the larger message, like, So given if such a patient comes to you, I think we actually did a trach and took a biopsy.
But
Here,
most
yes,
of the
Rajesh.
time, whenever we take such patients, the tracheostomy consent is always there.
Right,
And you
right.
don't take the patient.
Right, right.
So you have to be prepared, and you counsel the patient and you take the patient.
Great. No, there's just a practical point of, just securing the airway and be safe, sort of, rather than doing hurry-burriedly in an emergent scenario, plan it well and possibly do. And any thoughts on, Aditya, on pre-op tracheostomy and outcomes? I know there are sort of mixed evidence there, so you just want to throw some light for the younger people in the audience for that.
Preoperative tracheostomy, especially when done in an emergency setting, I think we'll have to look at two things.
Right.
If somebody is doing it in an emergency setting, it
Right.
better be the highest possible tracheal ring where they can find a plane.
Right.
Because if the patient is eventually going to go for a surgery, then getting the new trachea to develop would be very difficult if it's a low tracheostomy. So a practical point would be to do a higher up tracheostomy
Great.
if it is necessary.
Perfect. Yes, you had another issue about.
I'm afraid I have very strong views. I think this is one indication for an emergency laryngectomy.
Yeah, I was also going to come that, So,
No, not an emergency.
Yeah.
If I have a patient like this, I'll sit with him,
Right.
make him or understand that you are eventually going to need a laryngectomy.
Right.
Make him understand
Yep.
biopsy is just a mere formality.
Right.
I'll prepare the patient for a laryngectomy.
Perfect.
Do a peaceful tracheostomy, put a DL scope, take a biopsy, send it for frozen, start raising the flap.
Yeah, yeah.
And I don't think there is a debate about this at all.
Right. No, I agree. I think
On one hand, we are trying to tell high-tech chemoradiation, this hyperfractionation. This is a straightforward scenario.
Right.
If your institution cannot give you a frozen section diagnosis on this kind of a set and is wanting to risk GA and all there is no
Right.
doubt about this at all. This man cannot avoid laryngectomy.
Absolutely. And that's the point actually I was arriving at. Right. All those things can be done. Yeah, of course, I think the paper that came out from the Indian was about emergency laryngectomy, in fact. So that was the paper that came in the Indian Journal in March, I think, this year. They're saying that post-COVID, there was a lot of emergency laryngectomies that were performed. That's some Indian data from some center, I don't remember, but maybe you can do that. So again, I think that's the fair way to go about. You can sort of, directly take the patient for surgery, do a biopsy, and many times I think that will be the safest, considering the fact that, as Aditya said, you do a tracheostomy, you run the risk of some seedling, and then maybe some people say that the prognosis is slightly worse because you have a larger incidence of stomal recurrences, and then subsequently you'll have some central compartment nodes which you'll have to clear. So that was the exact point that I was trying to bring out during this
Sir,
case.
Even if
Yes,
we are
Aditya.
going to do an emergency laryngectomy,
Right.
the patient will have to be intubated first in some situation.
Correct. So, you can do
exactly. So
the-
intubation, what I meant was airway control, not intubation, oral intubation.
So
I
the
meant that
point
was
is you do it in the same sitting.
Exactly, same sitting.
Same sitting. So the thing is that, instead of sort of staggering it, do it, take a biopsy, wait. No, you can sort of, the larger message that our seniors were trying to tell is that you do in the same sitting. If you're able to, if anesthetist is able to put a scope and then intubate, fine. Otherwise, do a trach in the same sitting. I think obviously the chances that, of seedling and all may not function.
I think it's very difficult to counsel the patient for losing an organ, no? For that,
Right,
without
but I think that will
biopsy
eventually sort of happen. So I guess you will have to spend a lot of time with the patient and the family and then ask him. But I think when we were training, we have done a lot of such emergency
What if we get
vasectomies,
any
emergency
unusual
laryngectomies.
pathology? And what if we get any unusual pathology on final histopathology?
No, that's what we're doing, a frozen section, getting a diagnosis, and then only proceeding. And that's what I think Professor said.
Counseling is, to me, I think it is much easier in this distress when he has a stridor and the relatives are there, and when you explain them that, you are going to have an end tracheostoma anyway. This tracheostomy is not going to go out. Even if we don't remove your larynx, this tracheostomy is a permanent tracheostomy for you.
Right.
So you want to get your cancer out, and most of the time they'll say yes.
Right. Yeah, the larger point was it's a dysfunctional larynx. It's anyway going to land up in laryngectomy if the biopsy frozen section comes as a... Rajesh, any final point, and then we'll move?
No, sometimes it's the other way around also, Kaustubhai. You counsel the patient for emergency trach, then they are not ready for that also. Leave apart doing a total laryngectomy. They are not ready for a tracheostomy also. So that is also a clinical scenario which we all face every day.
Yeah, and I agree. I think, but eventually, I think you just need to sit with the patient and their family, tell them that this is the eventuality, and then proceed. So I think we'll move on. I think the point is well made. It's a dysfunctional larynx, T4 nodes on either sides, 202 centimeters, mobile, and of course, and the fit patient. So obviously, I think we all understand. We go for surgery. Anybody from the radongs or medongs from the panel, would want to sort of differ? Yeah, Dr. Samir. Yep.
Sir, by the look of it on the imaging, the clinical profile, everything points toward a dysfunctional larynx. Right. The priority here is the airway compromise, so obviously you have to go for a tracheostomy and then plan for laryngectomy.
Right, fine.
There is no scope of preservation here.
Great. Yeah, Dr. Peretti.
Yes, I completely agree on the plane. The only thing that I have to exclude the presence of distal metastasis before doing the total laryngectomy, because if they present mini met, probably the track is enough.
So we did have a CT of the neck and chest.
Okay.
But chest I didn't sort of project because it was normal. So I think that's a point well made. Yes, I think. Yep.
I have found that in these patients where you know that you're going to need chemo-RT later,
right.
I think it's better to defer the TEP and do it secondarily.
Right. Okay.
I think the complication rates are significantly higher when you need chemoradiation. At least that's true for me. I'd like to.
Yeah, I think that's some. First, I'll just open it up to the panelists. And anybody, Rajesh, Aditya, or Dr. Do you agree with that, or do you sort of put it in this scenario? I think you can sort of, agree to differ or something. There's absolutely no problems.
Sir, in my experience, just...
Yeah, please. Yeah, please, go ahead.
Just to say, in my experience, our experience, we don't see any difference even if patient has to go for chemoradiation after TEP placement.
Right.
So there are no more complications
Okay. Yeah, you had a point.
Same at our center, that we are doing primary placements mostly, and, and also in the post-operative settings before the CTRT, and the results doesn't vary much.
Okay. Fine. I think there are different viewpoints. There is nothing compelling or nothing contraindicating it, or sort of one way or the other you may choose to do. But the other point was about thyroidectomy and central compartment. I think anybody wants to sort of address, because this was obviously exolaryngeal coming outside, involving the thyroid. So how do you go about it? Is it total, or anyway, Rajesh, Aditya, Tashneem, how
so it will depend, if it's a extrathyroidal on the ipsilateral side.
It's coming both sides.
Yeah, both sides. So it will be a total thyroidectomy.
Right.
In this case.
So, okay. And central compartment also you would sort of do in such cases?
Yes, the pretracheal and the paratracheal will address both.
Perfect. Yeah, okay. So in general, I think you would require a bilateral neck dissections and a total thyroidectomy, laryngectomy with central compartment as well. And this was the histopathology. I just want to bring our radongs and medongs in this. This is the biopsy T4A N2C. It was large tumor. PNI was present. LVI was present. Right side, the 2 to 5 were cleared. 3 out of 21, no extranodal. Left side, 3 out of 17, no extranodal. I think in anybody of Dr. Prapti,
yes,
you can take it up.
According to the final histopathology report, definitely the patient has a node positive, so definitely it will require adjuvant radiation along with the chemotherapy, concurrent chemotherapy.
Right. So you always chemotherapy, you would sort of... any of the medongs can take Dr. Asif, Dr. Deepan? Margins are clear. Yeah, margins are clear.
So then no DNE?
No ENE. Yeah, I think that's the... Only radiation. Any of the panel, Dr. Dr. Asif, Dr. Deepen, any thoughts from your side?
So, adjuvant chemoradiation, concurrent chemoradiation is necessary category 1 indication for margin positive or perinodal extension.
Yeah, both of them are not
present.
there in this patient.
So, we may not give chemo. And
Maybe a show of hands, how many would give chemo RT in the panel?
Because it adds to the toxicity, so much toxicity.
Right. No, in the audience, how many would give chemo RT?
Sir, sir, just to answer this specific question, are you worried about the number of nodes positive?
Right.
There's no any there.
So there's PNI, there's LVI, multiple nodes are positive. So I think there are a lot of risk factors. And if you see...
So if you go to, according to literature, there are some literature where multiple more than 4 nodes is little risky.
Right.
You can consider admittedly you have an incremental benefit in terms of outcomes also. Because after laryngectomy it is going to be difficult.
Wonderful. I think that's what Dr. Sarbani is there, the OCAT
So
person.
So I'll just say this is a larynx. You have the recently updated analysis of 3 trials, that is the RTOG, the ORTC and the 0234. Up to 5 nodes, they saw that there was a worsening of prognosis, but there was no benefit gained with addition of chemotherapy, even in the presence of ENE, you know, with the addition of chemotherapy, not ENE. So it still remains that it is positive cut margins and ENE. That are the factors that push for chemoradiotherapy and no other factors. So I don't know why because we have to be cognizant of the fact that it causes a lot of excess toxicity.
Right. No, because there was a slight difference if you see in the RTOG and ORTC. One trial, it did show that, you know, more than 4 nodes, as somebody pointed out.
2 nodes and more was what the RTOG included. And the ORTC did not have it. But then if you even go through the post-hoc analysis, it's only the cut margin positivity and the ENE that stands the year of multiple analysis.
No, I entirely agree. I think there's level 1 evidence for whatever you all said.
And basically the neopharynx which we are constructing after laryngectomy is already narrow than what it is. On top, unindicated chemotherapy means patient will practically will not be able to eat.
I want to ask panelists, is there role of the minor prognostic factors when 2 or more minor prognostic factors are
there? No, that's what I think that's why the case is sort of presented, like, you know, so I just wanted to...
So here now the NCCN adds to the confusion.
Correct. It says...
Because it says PNI plus you can consider concurrent
So that's the reason why I brought this out, like, you know, what in real world, like, you know, this patient is like, what would you sort of do? Radiation for sure. The only thing is whether you want to add chemo, and NCCN actually says selective. Like, no, some people may add, some people may not. Dr. De Cruz, any suggestions from your end to sort of... Right. Get the mic. Get the mic, sir. I just wanted to...
I would agree with what Sarbani said. There's no compelling data, but then if you look at both Raffaelli's paper and Zumsteg said more than 4 nodes positive, addition of chemo is beneficial. Now these are looking at large NCDB database. Even Raffaelli's paper showed that. So sometimes in these kind of patients, I think it's about talking between you, the multidisciplinary board, and the patient. Even for salivary glands, when I have multiple nodes, if you look at the paper, the NCDB database, it was detrimental in patients who got chemo-radio. But I think the majority of my patients, I kind of convinced them to take radiotherapy.
So, but it was Zumsteg paper afterwards, which is a post-hoc or a later analysis of the RTOG, the ORTC and the 0234, which says that there is no advantage of giving concurrent chemoradiotherapy even with 5 nodes and more positive.
That they say, and they also say, unlike in the oral cavity, the soft prognostic factors that you said, they have not been well studied in laryngeal cancers. So like PNI and LVI, although we know that they are strong negative prognostic factors in oral cavity cancers, they are not that much strong in cases, maybe it's not that much well studied, I guess, you know. But of course you have sort of mixed data, a propensity match study saying that there is a benefit. So again, it's a mixed bag, but you may want to give selectively as the NCCN, or depending upon the general condition of the patient, you definitely may want to give radiotherapy. So again, I think the larger take-home message from this was, of course, if the patient has a dysfunctional larynx, and this is something that we all know, so I'll possibly sort of, skip this and directly go to case 2. This is a 69-year-old gentleman, again, lumpiness, dysphagia, and this is the lesion for him, So he has a very large sort of a lesion. It's not polypoidal, it's slightly arising from the supraglottic larynx in the left part of the A fold. Little bit it's stuck in the posterior pharyngeal wall. Unfortunately, I don't have the dynamic images for this patient. But that's it, and there's somehow I think this patient had a PET CT scan done outside. It does happen, although there may not be an indication. A lot of people do walk in with PET CT scans, and the biopsy was a squamous cell carcinoma grade 1. There was a small node, again 2.46, but that's how it is. So it's a T2 bar N0 bar N1 supraglottic. Minimal extension in the piriform fossa. And I think just comments and how do you go about this? Both the vocal cords are mobile.
No, but he has no difficulty.
Absolutely
but
no
the
difficulty.
mass effect of
It's causing a ball, but I think in the dynamic, when we did the flexible,
so
we
you
saw
have a proper imaging with small cards.
we do have a CT, and somehow they had a PET
Can
scan
you show?
as well. This is the PET scan.
No.
But I don't have the full, maybe I have it, but it's in a different video here. I can show it, but believe me, the vocal cords are mobile. It's just a large tumor, about 3 centimeters into 3 centimeters. It's a magnified view, I think. So it's because in the endoscopy, it's a very magnified view, and that's why it's looking so big, but it's actually 3 centimeters into 3 into 2, that's it. So I think, looks large because what we do is we use our regular esophagoscopy to sort of scope these patients. So I think the scope diameter is large, the magnification is large. That's why it could look clean and large. Exactly, it's not that big. So comments from
biopsy confirmation.
Biopsy is there. It's a squamous cell carcinoma. It's grade 1. Supraglottics, minimal extension into the piriform, and I think. All these options are there, So any takers, anybody, I think I just sort of,
I mean, the vocal cord are mobile.
Vocal cord is mobile, and functionally he's fine.
The pre-epiglottic space is free.
No, it's much lower down. It's much lower down.
Yes, yes, it's free.
Yeah, it's much lower down. Yep.
Yes.
So it's lower down in the.
I put the patient in a microlaryngoscopy.
Right.
I remove the lesion.
Right.
And I look for the histology.
Right.
Because probably
the biopsy is done. It's a squamous cell.
No. Just the bulk of the lesion.
Right.
If I have a free margin.
Right.
It's all.
Neck dissection.
Neck dissection, yes.
Yeah. Okay.
Yes, unilateral neck dissection.
Okay.
So TLM plus neck dissection.
Great. I think any other views from the panel? Anybody can take it.
Avoiding the tracheotomy, probably.
Avoiding, yeah, absolutely, yep. Okay.
So, as of the discussion, we are considering this as a low bulk T2 disease with minimal extension into the hypopharynx. So, we are thinking about a conservative surgery here, but
right.
as well as you can have the option of organ preservation because the larynx is functional. And clinically, you said the patient is breathing and no dysfunction is there. So that could also be an option.
Right.
But I'm worried about the minimal extension into the hypopharynx.
It's just minimal. I think it's not polypoid. It's not rotating. It's just sort of a large component of it is sort of like this, but very minimal sort of because it's not that freely mobile. It's not like a pedicle and a tumor like that where we can easily pluck it out.
So I mean, this also is a candidate for organ preservation.
Right. So by and large, we agree that this is for an organ preservation. So is there any doubt in that? Whether you do it surgically or whether you do it non-surgically is the larger debate. Anybody? I think Professor Peretti has given his views. Any other thoughts from? Agree with Professor? Okay. Any of our medongs or adongs? Okay. I think we proceeded and did a transoral robotic surgery for him. Remove the tumor. Of course, we addressed bilateral neck because it was in the piriform. Of course, you may do it unilaterally as well. This is the picture of the post-operative day 5 for him. And histopathology, again, it's just one node 8 millimeters. Margins were free, no external nodal, any adjuvant sort of, thing.
Sir, this is a very particular and relevant question actually that was coming into our mind, maybe probably most of the audience.
Right.
So when have you selected a patient for a conservative surgery as regard to TORS? So how many of these patients are landing up in adjuvant treatment, and how would you consider, I mean, T2N0 would always be considered as a single modality, as you discussed from the morning.
So pre-operatively we didn't know. So there was a small node. The SUV max in the primary was 20 because the PET was done. So we have that information. In the node was only 2 and was not looking that significant. Again, because we cleared the node, we discovered in the pathology that's just 8 millimeter node there. So often that's happened in real world. I just wanted to understand, anything different you would want to do in the hindsight, or
You have given, I mean, there's always an option for the further treatment, and you have given a fairly good outcome on this.
Right. Mithali, you wanted to make a point, then Professor Kausab, the last word, I think.
So please. So surgical management would have encompassed removal of the arytenoid as well, I presume?
It was just hugging there. So a part of it was removed. It was not involving that node. It was in the free border, and it was slightly stuck in the posterior pharyngeal wall.
So how comfortable are the surgeons to take out the arytenoid routinely in such conservative laryngeal surgeries, and the resultant aspiration?
In this patient, of course, as you notice now, we didn't take the arytenoid. It was preserved in the sense.
In a setup where there is no robotic surgery, we don't do. Then
that's fine. That's fine. You could have done it as a transoral laser, I think, because we had the robot.
CTRT. We can send it for CTRT.
Okay.
T2 case.
Right. Okay, I think fair enough. I think Dr. Kausab, you had a point.
After this histopathology report, I think in our tumor board we'll require some more data, like 8 millimeter node with how was
nothing,
it 8 millimeter node with 8 millimeter metastasis, or was it a 1.5 centimeter node with an 8 millimeter metastasis?
No, it was a sub-centimeter node.
It was a sub-centimeter node, and LVI, PNI,
nothing.
Negative.
Grade 1.
I think even with this one node positive, we can observe this patient.
Avoid radiation.
Avoid radiation.
Yeah, I think that's what I wanted to add on, because one node is positive. Traditionally, we say that maybe node positive, you would tend to radiate, but in this particular scenario, it's already got 3 more cases, but almost interesting.
So in all these cases, our main intention is we give patient less modality of the treatment.
Right. So you want to give or don't want? Because as I said,
I don't want to give in this case, particular case, but the main aim should be that surgery should suffice in any of the cases. We should select such cases in which the adjuvant RT is not indicated.
Correct. That is said. I think we all understand that, but sometimes in real world we are thrown scenarios like this wherein you have done a neck dissection, you've got a node 8 millimeters. So I just wanted to understand, because textbook says you can radiate, but in real world you may sort of want to observe, because the benefit as such in such patients for radiation therapy may be very, very less. Dr. Sarbani, you want to take your final word on this?
I won't do that. So I want to ask you, because I don't know the answer to the question. Theoretically speaking, this is a T2N1M0.
Correct.
That means stage 3?
Correct.
So stage 3 theoretically
by logic,
calls for multimodality treatment.
Right.
I also would maybe not treat, because if I know the cut margins are negative and all, I will not treat.
Right.
But then there's no answer.
Yeah. Right. There's no answer. I think because there is some data to suggest, even in earlier when they used to sort of do laryngectomies for T3 larynx, at that time also there is a subset of patients, they said that don't give radiation therapy, the benefit is same whether you give or not. So extrapolating that data, this patient to give or not is the larger dilemma,
There's no answer, so that's why the case is here.
Yeah, some other subsite.
Right.
Most of the evidence is from oral cavity. So you have PT2PN1 versus a PT1PN1. So for the PT2PN1 in the oral cavity, there is evidence in the sense it's not level 1, but all the studies that are there support the use of adjuvant RT in those patients, even for overall survival. But in the PT1PN1, you would have to discuss it out with the patient, because the locoregional events are lesser with the use of adjuvant RT, but there is no advantage in terms of the overall survival. But there is data discussing this issue of PT2PN1, PT1PN1 in the oral cavity and the oropharynx. There is data. Yang, you've got Kramer, the recent papers from Kramer. You have. Yes, sir. Kramer's thing clearly tells you that actually it's again a prospective German study, but it is not, it's a prospective database that has been studied. Right. But there again, it tells you that PT1, PN1, you need to discuss out with the patient. You can't just give it for all. Fine.
I think in the interest of time, I'll just quickly show one last case and be done with it. Like, again, a 53-year-old male, dysphagia, Hopkins, supraglottic, the pre-epiglottic space in which we have done a, please, I hope this video plays. Yeah. So this is how a functional assessment of, again, it's in the supraglottic, both vocal cords are mobile. It's just reaching up to the oropharynx. So this is how the functional endoscopic evaluation of swallow is done. Both vocal cords are mobile. It's a lesion in the supraglottic going onto the oropharynx. And in fact, can I go to the next slide in this? Yeah. So this is how the interpretation of a speech language pathologist. He said a PAS score of 4. There was just one mild event of a PAS score of 7, but they gave a digest score of 2. Preventive swallow therapies were initiated for this patient, and finally the management. So this is T3 and N0. T3, N0, pre-epiglottic space with a Fee's interpretation of a PAS score of 4. There was just one mild event, but I think the speech language pathologist said it's possible with exercises. She said that she would get the patient over. So I think panelists, anybody of our redonks, some. Pardon? It is a T3 N0. It's supraglottic going onto the oropharynx. Both vocal cords are mobile. Swallow is quite good. And
Arvind, I think.
Yeah, we are done. We're done. I think.
Yeah, last comment. Just one last comment.
Yeah, sure. I think this is the last case, and we're done.
The last comment.
Functional aspect is fine. Yep. Yep. You take a mic and.
So here the question comes, as Riku sir already mentioned, there are some evidence for regarding pre-epiglottic space involvement, which does inferior in RT, but I don't think that's
it's
a very
not,
strong
I
evidence.
don't think it's inferior. That's what he.
So
no, he said that surgery is a possibility in such scenarios. He didn't say. I think.
So extension into the oropharynx wouldn't matter for conservation as such, because the larynx is functional.
Larynx is functional.
So this is an intermediate larynx, T3 and 0, as we are debating the whole morning.
Correct.
So this also can go into organ preservation.
Yeah, definitely organ preservation, obviously, because it's a T3 and 0 with a functional larynx. My only thing is surgical versus non-surgical. I think, again, in the interest of time, I just allowed to cut it short because it was extending into the oropharynx. We decided to give for concurrent chemotherapy and radiation. And patient is on this therapy. So I think, again, a Fee's evaluation, as Vishal had pointed out in the morning, and Dr. De Cruz had pointed out during his thing. Yeah, Professor Paretti, I think last word from you. I think
yes, I missed the imaging, because the imaging
imaging just shows that it's
superficial involvement on the base of the tongue or deep invasion.
It is going into the base of the tongue.
How much? Because it's different if you involve deeply or superficially the base of the tongue.
It is involving a little bit deeply only in the base of the. The imaging had shown. I mean, the Fee's.
Yes, I need the sagittal plane of the imaging to evaluate how deep it is, because it says superficial involvement is a young patient, 50-year-old, fit patient, so supraglottic laryngectomy is feasible with a double bilateral neck dissection. If the invasion of the base of the tongue is deeply, I agree that chemoradiation could be an option.
Okay, fine. I think, so both the options are there. We thought like, because it's going slightly higher up and deeply chemo. I think in the interest of time, I'd like to stop and thank all the panelists. I think we had I had 2 more cases, but then for another day, maybe you can, Dr. Kaustubh, you can call us for another day. We can have a more elaborate panel. Thank you for the opportunity. Thank you. Bye.